Today I am going to talk on the clinical approach to a child with an acutely twisted neck. Now, this is an important clinical problem and it can be quite common, but it is very important to suspect, because if you do not suspect, there is a chance that you may miss it and there can be a delayed diagnosis made. Now, I would like to start my lecture with this interesting video and keep looking at this child. Now this child, you can appreciate always keeping her head turned towards the right side, right? So mother is doing movements and the child continues to keep the head towards right side. Right, so it's very important to evaluate in detail such children, because the causes can be numerous and some of the causes can be quite detrimental to a child's health and they need to be referred early to a specialist. Therefore, it's very important that we know and practice the correct approach to a child presenting with torticollis. So torticollis is made from the words tortus and collum, which are the words from the Latin, and that essentially refers to a twisted neck, or torticollis in Latin. And in this condition, the top of the head is tilted towards the affected side and the chin is pointed away from that side. And there are numerous causes that can cause torticollis in a child, and importantly, any injury or inflammation of the cervical muscles on one side of the neck can result in torticollis. And the most common muscle, as you all know, is the sternocleidomastoid. However, other neck muscles like splenius, trapezius, scalene and platysma muscles also can get involved. And the sternocleidomastoid muscle is innervated by the accessory nerve, which is the 11th cranial nerve, whereas most of the other neck muscles are innervated by the cervical nerves involving the cervical nerve roots C1 to C8. How is torticollis caused? So, like I said, there are a number of causes and you can broadly categorize them as congenital and acquired. And congenital torticollis sometimes is apparent when you do the postnatal examination of a newborn. And you can appreciate the newborn is keeping the head to one side. And it can be, again, it can be sometimes due to the compression of the cervical nerves, or it can be an intrauterine injury that happened to the sternocleidomastoid muscle, or an injury that happened to the sternocleidomastoid muscle during the birth process. And the acquired torticollis can be caused by a number of causes, and the clinical important ones include neck infections, neck inflammation, and sometimes the neck muscle, especially the sternocleidomastoid muscle, can be shortened due to fibrosis, and there can be sometimes excessive contraction due to certain central nervous system abnormalities. And torticollis can also result from mechanical insults like direct trauma to the neck, like that can occur following road traffic accidents, and compression injuries. Let's first look at congenital muscular torticollis. It is the most common type of congenital torticollis and it's seen about 0.3% to 1.9% of the newborns. There are three types of congenital muscular torticollis. It can be postural, muscular, or can present with a mass in the sternocleidomastoid muscle. So postural means the child physically appears completely normal apart from torticollis, and it can be due to the postural preference, and there is no evidence of muscle tightness or restriction to movement noted in any of the neck muscles. Whereas muscular torticollis can occur due to tightness in the sternocleidomastoid muscle, or and that can result in limitation of the range of movements of the neck muscles. And in the third form, there can be a mass in the sternocleidomastoid, and that can lead to thickening of the sternocleidomastoid muscle. So here what you have to understand is sometimes there can be sternocleidomastoid shortening, sometimes there can be sternocleidomastoid mass, and sometimes neither can be there, and still the child can have congenital muscular torticollis due to the postural type. Now this video shows a neonate demonstrating the torticollitic posture. So baby's head is tilted or turned towards the right side, and the most likely pathology or the most likely cause in this child is the congenital muscular torticollis. So it's very important to examine the neck of such children and feel along the sternocleidomastoid muscle to elicit any tightness or presence of a mass over the sternocleidomastoid muscle. So congenital muscular torticollis occurs mostly due to unilateral shortening of the sternocleidomastoid muscle. It can be due to abnormal muscle development or muscle injury that happened during the intrauterine period or during the birth process, or presence of fibrosis within the muscle, or presence of abnormal intrauterine posturing leading to muscle fibrosis. And often these infants have a history of complicated deliveries, presenting with abnormal presentations like breech presentation, and sometimes associated with hip dysplasia and head shape abnormalities including plagiocephaly. And in a twin pregnancy, the first twin is said to be at a higher risk for having torticollis. Although congenital muscular torticollis is the most common cause of torticollis seen in a neonate or a newborn, rarely ocular causes, neurological and occipital vertebral causes can present with congenital torticollis. Therefore, it is very important to think laterally and do a detailed assessment to rule out other associated problems in children presenting with torticollis if your neck examination is completely normal. Let's then look at acquired torticollis. Acquired torticollis happens in a child who is otherwise well, and it is most frequently seen in older children. And it can occur secondary to multiple causes like mechanical injury to the neck and infections of the head and neck, and preceding history of trauma or surgery, or certain acquired neurological conditions. Now, the children presented in this images have subtle torticollis. So sometimes it may be very difficult to elicit torticollis, especially in the child on image 1, right? However, certain neurological conditions like brain tumors can sometimes present with isolated torticollis. Therefore, it is very important that you pick up the physical signs. So from the acquired torticollis, we'll first look at mechanical and trauma-related muscular torticollis. It is the most common cause of acquired torticollis, and often these children have a history of recent minor trauma to the neck or history of abnormal positioning of head during sleep. And especially this is the very most common variant, like somebody keeping the neck in an abnormal posture during sleep, and on the following morning wakes up with pain and difficulty in turning their neck and head, and which is very abrupt onset. And I'm sure all of you have witnessed or have had this type of torticollis sometime in your life, and it's quite common, and that occurs due to the muscular torticollis. That happens due to the minor injury that happens to the muscle because of the persistent abnormal positioning of the neck that happens during the sleep. And this type of muscular torticollis usually resolves with simple analgesics alone. And sometimes when you sleep to one side, the sternocleidomastoid muscle can go into spasm and can result in minor degrees of regional neck inflammation. And therefore the torticollis can last for a few hours to few days. And other serious causes of secondary muscular torticollis include atlantoaxial subluxation. Now, atlantoaxial subluxation is seen more commonly in children with trisomy 21 and rarely in all other children as well. And they usually give a history of neck pain on a background of previous head and neck trauma. And if it's severe and if the nerve roots are compressed, they can present with neurological deficits in upper and lower limbs. And cervical spine injury we need to suspect in the presence of a major trauma history or a road traffic accident. And sometimes same injuries can result in formation of hematoma, resulting in a spinal cord hematoma, and that can present the child with muscular torticollis. Infective causes are the next most common cause of acquired torticollis, and I'm sure all of you have seen children presenting with cervical lymphadenitis. They present with acute onset, neck pain, neck swelling, sore throat and fever. And most of these children can be managed with supportive treatment. However, if you suspect a bacterial infections, antibiotics are warranted. And since the most common microorganisms that cause lymphadenitis include Streptococcus pyogenes, and sometimes anaerobic organisms, the antibiotic that we use should cover such organisms. And with regard to investigations, if the child appears ill and toxic, doing basic hematological and biochemical investigations including full blood count CRP and microbiological investigations like blood cultures are warranted. And to look for evidence of lymphadenitis, or to look for the involvement of the regional neck structures, a neck ultrasound can be performed. And if it is due to a viral infection like viral upper respiratory tract infection and pharyngitis, it can be managed with supportive treatment alone. However, sometimes these infections can be quite serious. One such infection is a retropharyngeal abscess, and Lemierre syndrome is another serious infection. Now, Lemierre syndrome occurs due to a formation of septic emboli in the internal jugular vein that occurs secondary to a regional neck infection. And both these conditions present with severe redness and swelling and warmth and reluctance to move neck with limited neck extension. And these children can also manifest with upward eye gaze, and they can appear quite ill, irritable, toxic. And children with retropharyngeal abscess can present with drooling and difficulty in eating as well. If the child is having drooling and having difficulty in breathing and difficulty in kind of opening their mouths, throat examination is best avoided because of the risk of significant airway compromise. And with regard to imaging, we can perform a cervical spine X-ray if the time permits, and if in the case of retropharyngeal abscess, you can appreciate an increased prevertebral space with areas of collected pus. However, the investigation of choice is the CT neck with contrast, which shows the structures with better soft tissue enhancement. And Lemierre syndrome is often refractory to antibiotics, and the differentiating features of Lemierre syndrome include focal tenderness along the course of the internal jugular vein, and sometimes association with possible ocular complications and the risk factors for septic emboli. And rarely, meningitis and right upper lobe pneumonia can present with acute onset torticollis. The picture here shows a child with Lemierre syndrome, and here the left side internal jugular vein is affected, and you can appreciate the swelling and the erythema on the left neck. And this will mimic lymphadenitis. However, in most cases the lymph nodes will appear normal, and it is mainly the internal jugular vein that is affected. Let's then look at the neurological causes of acutely twisted neck or acute or chronic torticollis. Now, most of these neurological causes are serious. Therefore, it is very important to diagnose them timely. And examples include posterior cranial fossa tumor, Arnold-Chiari malformation, space-occupying lesions within the cervical cord, and sometimes chronic neurological disorders like cerebral palsy and spasmodic torticollis. Children with posterior fossa tumor can present with other clinical features like presence of cranial nerve paralysis, unsteady gait, and pyramidal signs or the long track signs. And children with Arnold-Chiari malformation can present with chronic headache, which is worsening and relieved by vomiting, and presence of papilledema on fundoscopic examination. And children with cervical space occupying lesions can present with specific tenderness over the cervical spine. And the image on the left side shows a child with trisomy 21 here. And if you notice torticollis in a trisomy 21 child, it is very important that you suspect atlantoaxial subluxation, because they need to wear a cervical collar and the cervical spine need to be protected. And the other three images are of the same child who had a posterior cranial fossa tumor. So the first image shows the torticollis before the surgery, and then the presence of torticollis and its improvement 6 months and 42 months after the tumor resection. Let's look at the ocular causes or the eye-related causes of torticollis. Eye-related causes are also an important cause of torticollis in a child. This means when an older child presents with torticollis, it is very important to refer that child to an eye surgeon to look for and to rule out eye-related causes. Examples include congenital paralytic squints, refractory errors, and congenital nystagmus. So these conditions may need prescription of a spectacle or sometimes ophthalmologic surgery. And children with squint, they adopt a torticollitic head posture to maintain the binocularity and to optimize the visual acuity and to avoid double vision. And the mainstay of management of ocular torticollis is surgery. And sometimes the nystagmus can present in children with spasmus nutans, which is not actually an eye condition, but the child can present with acquired torticollis with nystagmus and head bobbing, the cardinal features of spasmus nutans. And these children are otherwise neurologically normal. And let's look at this video. Now this video shows an older child who presented with acute onset torticollis. In addition, you can appreciate the child is having dystonic body posturing as well. So this child is having both dystonia and torticollis. So when a child is having acute dystonia and torticollis, most likely differential diagnosis is an acute dystonic reaction. And the most likely reason for an acute dystonic reaction is one of the drugs. So it's very important to take a drug history when a child presents with torticollis. So let's look at what drugs can result in torticollis in a child. There are several classes of drugs that can present with acute dystonic reactions and torticollis. For example, antipsychotic medications like haloperidol and chlorpromazine, antiemetics like metoclopramide, and accidental toxic ingestions of medications like carbamazepine, haloperidol, chlorpromazine, and phenytoin. So it is very important to take a drug history when a child presents with an acute dystonic reaction and torticollis. And sometimes, especially teenagers, they tend to take sometimes test or experiment with recreational drugs, and it's important to remember certain recreational drugs like cocaine and amphetamine, apart from their characteristic clinical toxidromes, these drugs can precipitate spasmodic torticollis. So torticollis can be seen, and it should be an important cause in your differential diagnosis in a teenager presenting with unexplained spasmodic torticollis. And there are a few other important causes of torticollis as well. For example, benign paroxysmal torticollis. Now in this condition, the child presents with multiple recurrent or repeated episodes of self-resolving, transient, brief, alternating torticollis, especially during the infancy period. And sometimes these episodic torticollitic episodes can associate with autonomic symptoms like vomiting and pallor and drowsiness and irritability. And this is a self-limiting condition with a good prognosis. But sometimes when they occur repetitively, the parents can be very much concerned because it can be sometimes a seizure. So it's one of the important differential diagnoses of a child presenting with pseudo seizures. So what you need to tell parents in such condition is, this is unlikely to be a seizure, and this child, the condition is likely to be resolving with time, with no intervention. However, this can quite complicate the differential diagnosis, and it may be sometimes difficult to differentiate. So it's an important differential diagnosis of a child presenting with torticollis. And younger children, especially young infants, can have severe reflux. And when you have severe reflux as a young infant, they adopt a posture that mimics the Sandifer syndrome. So Sandifer is characterized by having an opistotonic-like posture. And with that, the child also keep the neck to a side, resembling torticollis. And so torticollitic posture and the dystonia can be the presenting feature of a gastroesophageal reflux disease in a young infant. So it is one of the important differential diagnoses. And also, musculoskeletal problems are common in children with juvenile idiopathic arthritis. So in a child with multiple joint pains and presenting with torticollis, then you have to suspect, but this is an uncommon cause of torticollis. Right, so the image on the left side shows an infant demonstrating the opistotonic posture with the torticollis, and this child is having gastroesophageal reflux disease. And the second child is wearing a cervical collar, so likely to be having a muscular torticollis or a neurological cause related torticollis. So it is very important to understand the causes of torticollis or the twisted neck in a child are numerous. However, we should be able to do a clinical evaluation and then differentiate, or to narrow down our differential diagnosis to arrive at a diagnosis without delay. Right. Let's now look at how we can perform a structured assessment on a child with acutely twisted neck or torticollis. Now you know the common causes that can result in an acute torticollis. So it's just a matter of differentiating between these conditions based on their basic clinical features. So history is very important. So history gives the most information that can help you to narrow down your differential diagnosis. First of all, look at the child. Now if your child is a neonate, it's more likely to be a congenital muscular torticollis. And if the child is young, like young infant, the other differentials include Sandifer syndrome, spasmus nutans, and benign paroxysmal torticollis, because they are quite uncommon in older children and teenagers. However, if torticollis presents newly in an older child or a teenager, then the differential diagnosis include acquired muscular torticollis, atlantoaxial subluxation, and infective causes like retropharyngeal abscess and Lamier's syndrome. And look at the duration of the torticollis. If it's acute, we had to suspect an infection or an injury, or sometimes due to a drug ingestion. And if it's long term, the differential diagnosis mostly include congenital muscular torticollis, or sometimes neurological or a ocular related cause of torticollis. So in such children, it is very important the child to be seen by an eye surgeon and a neurologist, because your differentials include brain tumors and ocular problems like refractory errors and congenital squints. And then in those with acute torticollis, look for presence of specific risk factors. For example, acquired muscular torticollis can be precipitated by abnormal sleeping position. So eliciting such history help you in making the diagnosis early. And look for a history of recent trauma or recent surgery in the head and neck region or the cervical spine region. and also inquire about history of recent ingestion of medications like metoclopramide or anticonvulsants and antipsychotic medications. And then look for fever. If the child is feverish and ill-looking irritable, then your differential diagnosis include infective causes like retropharyngeal abscess and Lemierre's syndrome. And then look for evidence of trauma. In the presence of trauma, the underlying causes include cervical spine injury, cervical spine hematoma, and atlantoaxial subluxation. And remember, atlantoaxial subluxation is seen more commonly in children with trisomy 21. Let's now look at how we can investigate a child with torticollis. Now, we should not do a long battery of investigations, but our investigation should be guided by careful clinical evaluation, which includes a detailed history and physical examination. And that help you to narrow down your differential diagnosis, and that help you to narrow down your list of investigations as well. And apart from investigations, it is very important that you decide or to get the specialist opinion from specialties like neurology, ENT, orthopedics, ophthalmology, depending on the likely differential diagnosis. And some of the causes like abscess formation are infectious, like infection related. Therefore, microbiological investigations are also warranted, including sending throat swabs and doing blood cultures. And radiological investigations, including ultrasound, CT or MRI, depending on what you want to see, are indicated in different conditions that result in torticollis in a child. So let's look at the blood investigations and radiological investigations that can be done in a child with acute torticollis. So in terms of radiological investigations, if you suspect an injury, especially a cervical spine injury or retropharyngeal abscess, you can request an X-ray of the cervical spine, anterior, posterior and lateral view. In case of retropharyngeal abscess, you'll be able to appreciate the increased width or the diameter of the retropharyngeal space. And in the presence of a cervical spine injury, you will be able to appreciate the injury that has happened to the cervical spine. And if you need better soft tissue enhancement and if you want to see the subluxation, then you have to go for more advanced investigations, including CT. And if you are concerned about a cervical spine tumor or a vascular malformation or hematoma or possible infection like osteomyelitis of the cervical spine, then MRI of the brain and cervical spine is indicated. And conditions like cervical lymphadenitis and other soft tissue infections and congenital muscular torticollis due to sternocleidomastoid mass formation, you can request an ultrasound scan of the neck, and you are likely to see specific abnormalities in each of these conditions. And with regard to hematological or the blood investigations, you can do a full blood count, a C-reactive protein and blood culture, especially if you suspect soft tissue infections in the neck. And if you suspect bacterial pharyngitis, tonsillitis, you can request a throat swab. And if you suspect a bleeding condition that results in hematoma formation, you can request a coagulation screen. And if you suspect a lymph node abscess or retropharyngeal abscess, osteomyelitis, you can drain the pus and then send those pus for cultures. And sometimes, for example, benign paroxysmal torticollis can confuse or can mimic a convulsion. So EEG is important for ruling out seizures in such children. Let's now look at treatment. Again, a treatment depends on your likely diagnosis, and there is no uniform treatment for each and every condition that results in torticollis. Most of the muscular torticollis, whether it be acquired or congenital, and if it causes pain, the most important thing is the management of pain. And the pain should be managed with simple analgesics, because some analgesics like diazepam, if you use for a long period of time, it can result in tolerance and dependence. So such pain relieving or the sedative agents should be better avoided. And congenital muscular torticollis can be managed with appropriate handling, positioning and physiotherapy as well. So they have a place in management of congenital muscular torticollis and some of the variants of acquired torticollis. Oral diazepam as a symptomatic treatment for spasmodic torticollis, it can be given, but like I said, it should be used with caution because of the risk of development of tolerance. And depending on the etiology, you can use specific pharmacological and surgical interventions to manage the underlying cause of torticollis. So with regard to congenital muscular torticollis, positioning and handling strategies and physiotherapy play a key role in managing such children. And children with severe persistent torticollis and those with a neuromuscular disability can be referred to orthopedic surgeon for surgical lengthening procedures. And children with toxin to reduce the spasticity in the sternocleidomastoid muscle. And if you look at the prognosis of torticollis, it depends on the underlying cause and its severity. For example, muscular torticollis and positional torticollis have a good prognosis and likely to settle with time, whereas a child having torticollis secondary to a posterior cranial fossa tumor, the prognosis can sometimes be guarded, especially if the tumor is located in the brain stem region. And treatment further, so mechanical torticollis can be best managed with analgesics, and analgesics should be the paracetamol or non-steroidal anti-inflammatory agents. And in the presence of a major trauma on the cervical spine injury, it's very important that you immobilize the cervical spine. And if you suspect a retropharyngeal abscess or Lamier's syndrome, it's very important that you treat with intravenous antibiotics. And you can drain the pus, and then depending on the culture results, you can change your antibiotics depending on the sensitivity pattern to the various antibiotics. And ENT referral and ophthalmological referral and their inputs are also vital in certain types of torticollis. And the other variants of torticollis, especially if it's Sandifer syndrome or due to the severe gastroesophageal reflux disease, it's very important that you give the specific treatment, which is anti-reflux therapy. And upon reflux therapy, the torticollis will disappear. So you can practice both non-pharmacological as well as pharmacological means of managing gastroesophageal reflux disease in such infants. And children who poison themselves with drugs, with antipsychotics and anticonvulsants, so we have to follow the appropriate toxicology guideline and to manage their comorbidities as well. And in the presence of a space occupying lesion, it's very important that these children are imaged and then referred early to the surgeon or the oncosurgeon for early tumor resection. So let's recap. So in a nutshell, this slide shows the common causes of torticollis and what we can do about them. Now, torticollis can be broadly categorized as congenital torticollis and acquired torticollis. And congenital torticollis, the most common variant is congenital muscular torticollis. However, there can be other variants like congenital ocular, neurological and occipitovertebral anomalies. And most of these babies can be managed with positioning and handling strategies and physiotherapy. However, we can consider referring such babies to orthopedics and for botulinum toxin if their torticollis is resistant to handling strategies and physiotherapy. And acquired torticollis can be categorized broadly as mechanical and non-mechanical. And again, mechanical can be categorized broadly as traumatic and non-traumatic. And traumatic mechanical torticollis, the examples include injury to the sternocleidomastoid muscle, cervical spine injury, and atlantoaxial subluxation. So in such children, investigations include imaging, which includes cervical spine X-ray, CT, plus or minus MRI of the head and neck. And most of these children will need opinion or the support and the advice and the further management by the neurosurgical and the orthopedic teams. And mechanical non-traumatic examples include transient mechanical torticollis, for example sleep positioning related, or regional muscle inflammation. So they can be managed with supportive care alone with simple analgesics including paracetamol and non-steroidal anti-inflammatory agents. And with regard to non-mechanical type, they can be broadly again categorized as infective causes, neurological causes, and others, and ocular related causes. And infection related causes include cervical lymphadenitis, viral upper respiratory tract infections, retropharyngeal abscess, Lemierre syndrome, and rarely right upper lobe pneumonia. So all of these conditions warrant timely intravenous antibiotics. Sometimes you can manage with oral antibiotics, and imaging to look for evidence of pus formation, and if pus formation is there, then you will have to get the opinion from the surgeon for arranging the drainage. And neurological causes can be due to spinal cord or posterior fossa tumor, atlantoaxial subluxation, dystonia, anulcari malformation, spinal cord hematoma, and rarely idiopathic intracranial hypertension. So most of these conditions will need inputs and the specialist opinion from the neurologist or the neurosurgical team. And investigations wise, most of these conditions need detailed neuroimaging including MRI head and spine. And other conditions include conditions like benign paroxysmal torticollis, for which the treatment is reassurance, and Sandifer syndrome, for which the treatment is reflux medication, and ocular torticollis, for which the treatment include correction of the refractory error plus or minus ocular surgery. So their treatment depends on the underlying cause. So I hope you gathered a good understanding about the various causes of torticollis in a child, and then the approach that we need to follow. And remember, history, the detailed good history and physical examination are key to evaluating a child with torticollis. And investigations have a limited role, and these investigations include radiological investigations, blood investigations, and sometimes microbiological investigations. However, we should not do like a detailed battery of investigations. Our investigations should be guided by always by the detailed history and physical examination findings. Thank you.